Welcome, everyone, to another brand new episode of the Preventive Medicine Podcast. And if you guys are returning to this podcast, then thank you so much for your continued support. We have had a lot of phenomenal episodes and a lot of phenomenal feedback on these episodes, so thank you so much. And if you are a brand new listener, thank you so much for clicking on this podcast. We hope that this episode can provide you some sort of value. And if it does, then make sure to go check out the rest of our podcasts because I think that there's a lot of other value to be had in there. And lastly, I'm making kind of a huge deal out of this right now, and it's because we want to reach new audiences and really grow the message of prevention. And that is, if you really want to help us out, whether you listen on Apple Podcasts or on Spotify Podcasts, go and leave us a 5-star rating and kind of drop a review of what you enjoy about the podcast, and it'll really help us grow. That's one of the best ways for podcasts to grow. But let's get the rambling out of the way. I am super excited for this episode because this is something that we have not approached at all. Like looking at prevention, we haven't approached it through this lens at all. So today I'm very excited to get into it. So here we go. Overcoming saber-toothed tigers and woolly mammoths, we must now face a new enemy, ourselves. With the rates of diseases such as heart disease, stroke, diabetes, depression, and many others ballooning, we must find a better solution to these modern epidemics. Welcome to the Preventive Medicine Podcast. We believe in building a foundation of health by means of prevention so that you can build the life you want and find fulfillment with no barriers. Hear from experts around the country on how to take your health into your hands. Take control and build a foundation of health for the life that you want to live. And now, here's your host, Raghav Sharma. We hope you enjoyed the show, and if you do, please don't hesitate to subscribe and like for all of our future content. So today, we are talking about prevention from a completely new lens, as I was mentioning, and today's guest is Leoson Hoay, who serves as a research analyst and data steward at the University of Chicago Urban Labs. And he pretty much helps create data-driven solutions for public health problems. And you can see where I'm getting with this, where this is a completely new angle, something we haven't talked about. He spans and works in various fields using data engineering to help things like mental health counseling, environmental remediation with organizations in both the US, Singapore, and also in Australia. Leoson earned his master's in Computational Social Science from the University of Chicago and his undergraduate degree in psychology from National University of Singapore. And he's currently pursuing a master's in computer science at the Georgia Institute of Technology. So, Leoson, welcome to the podcast.
Thank you, Raghav. Happy to be here.
Definitely. I am very excited for this episode. So for the first thing is I mentioned a lot of things that you do, and a lot of our listeners might not be aware of what that is because we're all kind of within this health sphere. So what do you do? What led you onto this path? And tell us a little about yourself.
Sure. So thank you, Raghav, for that really detailed introduction. So I don't really have that much to add on to that. I can say that half of my day job involves developing statistical models, data analysis and visualization, and designing research methods to address public health questions. And the other half of it is in managing, the health lab's data infrastructure, the maintaining of privacy and security policies, and ensuring that the lab is legally compliant with laws such as HIPAA that protect the use of sensitive health data. And your other question was what led me to this path, right?
Mm-hmm.
So if I were to pinpoint an origin, it will probably be during my undergraduate years where I also joined a lab that focused on studying the challenges of underprivileged and individuals who are below the poverty line in Singapore. And back then, I was a psychology undergraduate. And because of that experience, I moved on to intern with the Singapore Prison Service. And even though I started out as an intern in the psychological services department, it was there that I realized that data is just so important in evaluating the effectiveness of various programs, be those programs like addressing specific outcomes like recidivism, or more like holistic outcomes like the health of incarcerated individuals. Because of that, I went on to do my master's in University of Chicago, and that was where I had the opportunity to start working with the health lab.
Definitely. What made you make that jump from psychology to data and using data? Because I know you mentioned that you found out it was very important and kind of
Mhm.
helping make a lot of these decisions. And I think a lot of physicians and other people in healthcare also realize that data is incredibly important, but we don't necessarily like completely switch because going from psychology to kind of computers and using numbers and all these things is a pretty big leap. What made you actually take that leap?
That's a good question, actually. I had a couple of mentors, both when I was interning at the prison service as well as in my undergraduate years, that um, what they basically told me was that I I could do a lot more with the skills that I had in programming and data analysis if I wanted to address problems at a larger scale. So back then, my initial aspiration was to be a clinical psychologist,
Hmm.
which in in many respects is very much focused on individual cases, individual clients.
Definitely.
So what my mentors said to me about addressing larger scale problems really spoke to me at the time, and so that is probably the main reason why I switched.
Sure. So you already had a background in some sort of coding languages and computer science.
Yes, so
Okay, got
I
it.
did a double major in
Okay.
media studies. Yeah.
All right, that makes a lot more sense because otherwise you have to completely learn coding and all that other stuff again. So
Hmm.
makes me feel a little bit better about myself too. So the number one question that we ask all of our guests on this podcast when they come on, given our name, is what does preventive medicine mean to you? What does it look like given your role and your experiences?
Yeah. From my experience, especially, I think the idea of preventative medicine means the development and study of methods that focus on actually maintaining good health and maintaining a good quality of life while also preventing the deterioration um, of such a quality of life, the prevention of disease, and basically anything else that can affect one's quality of life. Um, so, with that definition, I think this applies to anything from biomedical interventions to even healthcare policies and even environmental design, like anything that focuses on preempting health issues as opposed to dealing with it after it actually happens.
Yes, I absolutely love that. You mentioned kind of the environmental design and all those other things. And this is one of those aspects of preventive medicine that we typically don't think about because when we think of medicine, we're thinking of interventions within kind of the healthcare setting, whether it's a physician, a maybe like a dentist, a pharmacist, all of those kinds of traditional healthcare roles, physical therapist, whatever. But we don't think of it from a larger perspective. And I like how you brought that up, where you have the policy aspect, you have the environmental design. How are we designing our neighborhoods, our systems, variety of these things? And this is exactly why I have you on. So let's start diving into it. And the first thing is you use data to solve problems. How do we use this data to solve these problems? And what does that process look like?
Great question. So I actually think the power of data lies, not really with the data itself, because data has been around for a long time, but um, data has become much more important recently because of advances in statistical methods and especially like the computational power to process it. So one example, which I'm sure you're already familiar with, is in machine learning, right, for
Mm-hmm.
healthcare applications. So, for example, you can feed a statistical model enough images of chest X-rays and
Mm-hmm.
um, to use a very contemporary example, chest X-rays and maybe the COVID-19 diagnoses of individuals who went through these
Mm-hmm.
X-rays. And you can teach this model to a significant level of accuracy to flag potential COVID 19 sufferers just using the images themselves. Um, so that's one really good example, I think, like how big data is really transforming healthcare. And to speak to your point about urban design and preventative medicine, like another poignant example is when you're examining environments, when you're examining um, various aspects of medicine, like behavioral health, uh, um, respiratory health. Like you're not when if you're looking at it from the urban setting, you're not looking at individual patients anymore. You're looking
Mm-hmm.
at um, groups of patients. You're looking at these large data sets, right? and so many variables that you have to screen for. So to provide preventative solutions, you will want to actually identify like what are these variables, what are the patterns across large groups, and the only way to do that is really to have the infrastructure to store large amounts of data, have the infrastructure to be able to process them, and to create statistical models from them.
So would you say the most important part of this is not necessarily data collection, but the improv, like the making statistical models and continuously improving them to kind of hone what results you want to get out of them? Because a lot of times we hear like you're only going to get results for what you kind of measure and what you analyze for. So is improving those statistical models the main aspect of this?
I would say that is definitely one of the main aspect. The other main aspect that I will add to that is having an appropriate data infrastructure. So not just I mentioned storage, but there's also um, pipelines. So, for example, are you even collecting pieces of information that might be important? So, if you're recording data, say from physician visits, what what pieces of data are you recording? All that is important as well.
Definitely. And I think that's one of the issues that we do have in healthcare right now, where the data that is recorded is not necessarily going to help physicians give better care. It's kind of improving the efficiency of that care, whether it's like reduced number of rehospitalizations, reduced number of physician complaints, improved physician satisfaction scores. All of those things. That's a lot of what's measured right now from what I hear of my attending physicians. Given that my position as a resident, obviously I'm not like as exposed to these yet, but that's what I hear right now. So it sounds like we do need to improve the kind of data that we're collecting between these patient physician interactions so that we can hopefully get better results through that. And I also hate to sideline you here, but one of the other aspects of things that's like difficult in healthcare is kind of gathering the appropriate data, and that is because a lot of people who's like gathering data and setting these things up do not have a healthcare background, so they're kind of just looking at it from the business standpoint. So, is there something you
Mhm.
can speak about there?
Yeah, definitely. So I would say that uh, what you said is definitely accurate. So the people who are handling um, data transfers or even the storage of the data, or like if a researcher wants to use like a specific data set from a hospital, for example, um, doctors aren't the main people who are handling this process, right? It's
Hmm.
mostly administrators, kind of like what you said, and um, they may not have the same level of training or familiarity with the variables in the data set to speak to um, uh, sort of the sort of to discuss with the researcher like which variables are actually important for the
Yeah.
research. So that's definitely a problem. And another issue is also that um, a lot of healthcare data is obviously very sensitive and is protected by HIPAA, and individuals who handle these data sets have to be trained in how to ensure like the security of such data in order for um, the data to even move between different
Hmm.
organizations.
So, what are some of the protective measures that can be used for that? Because I know HIPAA law is something that's very important right now, and a lot of people are talking about it just because with a lot of this like vaccine stuff for COVID and whatnot, everyone just mentioning HIPAA. So, kind of, what are the protective measures that hospitals and these data sets use?
So I would preface my answer to that by sort of dividing the motivations for protection into two simple points. So um, all the protective measures are basically there to ensure that, first of all, like no third party is able to misuse the data or to identify um, uh, individuals based on sensitive information.
Hmm.
And obviously, the second reason is to um, protect the organizations which are, the guardians of such data, so
Hmm.
that uh, in case there is any breach, which may not happen because of anybody's mistake. It could be as simple as someone sending an email by accident while attaching
Or a
some sort of
cyber
sensitive
attack.
data. Exactly. Like it could be an external malicious actor or non-malicious
Hmm.
actor. So um, so all the protective measures are based on, sort of dealing with these two things. So one important protective measure is therefore to establish secure data enclaves. And what I mean by this is, say you have a place to store your data, right, and you want to do some kind of research with this data. um, for example, X-ray images, as I mentioned earlier. um, you want to make sure that the data doesn't move between different uh, I would say, like, virtual spaces as much.
Mm-hmm.
So building a secure data enclave includes having the storage, the analysis capability, um, and the ability to use this data as much as possible in the same place, so that you can manage access to this particular enclave very easily,
Mm-hmm.
right? And then if you're going to protect um, this data, you only have to protect, a single
Sure.
point of vulnerability.
Sure.
So that is one protective measure that is really important, and that's what we try to do at the health lab as well.
Definitely.
Um,
So I think a similar analogy, what it sounds like, is if you have like a bank vault and you have all the cash in there,
exactly.
instead of transferring the money back and forth when you need to use it between like one bank and another bank, and you can suddenly get hit by a robber in transit, you store as much of that data in one spot as possible within that bank vault and secure that and just kind of regulate access to it. So it'll be a lot easier to do it that way versus just constantly transferring it. That's what it sounds like, correct?
Yeah, exactly right. And an addendum to that is also um, instituting policies and making sure that staff remember that, don't do things like emailing data to each other. Um, don't use your personal machines to process such like HIPAA protected data, and
Mm-hmm.
etc. Yeah.
Definitely. I didn't think we'd ever be talking about protecting data on this podcast, but here we are. And that's why I love it, because we approach it through so many perspectives. But let's get back a little bit into the straight up prevention and preventive type topics. We talked previously on another Zoom call about some of the research that you've done, and one of those was in the cycling of the homeless population between a variety of areas, such as hospitals, maybe shelters, or whatever their housing situation is, and unfortunately, sometimes jails. Can you tell us a little bit more about this project?
And definitely. I'm excited to talk more about this. So, this project basically involved, as you mentioned, like three different sectors. And we had to merge data sets that we obtained from what is basically um, uh, organizations in these disparate sectors that don't usually talk to each other. Um, so, the whole rationale for doing this is that we hypothesized that a lot of individuals who experience um, behavioral health issues, who experience physical health issues, um, and also at the same time are experiencing other kinds of vulnerabilities, such as homelessness or being incarcerated. They are actually more vulnerable because of the fact that these things, while they look as if they happen independently, are usually attributable to various aspects of the person's life. For example, they just may not be born into a very fortunate uh, uh, family situation, and
Mm-hmm.
um, um, that makes them more vulnerable in terms of, when they contract or when they get a disease and seek help, they may not have appropriate coverage, or they may not have enough resources to even um, access appropriate treatment. And therefore, they end up in um, the public healthcare system a lot
Mm-hmm.
because these symptoms keep recurring, right? And then at the same time, so this is just a hypothesis. So obviously, I'm not referring to any individual subject here, but um, just imagine like somebody who is pretty desperate financially, and so they might, commit minor offenses in order to deal with this desperate situation, and they get caught for it and end up in jail. And some jails obviously don't have the appropriate healthcare services that this person might need as well. So when they get released from jail, they end up back in hospitals again.
Mm-hmm.
So we wanted to identify these individuals and also to um, observe some of the characteristics that these individuals possess that may become a pattern. And the reason for doing this is speaks to preventative medicine as well, because we want to pinpoint people who may be at risk of cycling between these
Hmm.
different sectors. And if we are able to get the variables that uh, seem to point most heavily towards them being at risk of cycling, then that can be useful for these various organizations. So when someone comes in, um, if they get this person's history, this person's uh, activities in the past few months or even a year, they may be able to say like, "Oh, wait, you're kind of at risk of so and so. Let us, uh, provide you with the appropriate treatment."
Sure. So this is definitely a very noble cause and a very noble issue, and something that should definitely be addressed, because even like as a med student, when I was rotating through some of those more public health and community facing hospitals that are maybe for the underinsured or uninsured, then you do see a lot of this. You see people cycling in between the jail system, the hospital system, and homeless shelters, just wherever the housing situation may be.
Mhm.
And everything you talked about is 100% true. I've seen it. And the question now is, what do we do with this data? How do we collect it? What do we do with it? And how do we actually help these people? Because it takes a tremendous amount of resources and kind of coordination between these three separate sectors, as you were talking about, to get them to do something. And this is about also people that aren't necessarily going to advocate for themselves, because they don't either have the agency, they haven't been brought up with the agency, they just don't know how a lot of these systems work. How do we use this data to actually help these people and prevent the cycling of this and hopefully the deterioration of their health?
Yeah, so those are two like very important questions, and I think especially like how do we collect this data? That really speaks to one of the challenges that we encountered during the project. So, um, uh, with such sensitive data, especially the data from the hospitals, um, we had to be extremely careful when linking these data sets. So, in order for to even get this project approved and for the organizations to work together, we had to basically create a protocol um, that ensured that even though we're like sort of linking individuals across these different three sectors, no single person, including anyone who's analyzing the data, ever sees like the actual names of the people
Hmm.
in the dataset.
Yeah.
Um, and no single analyst also sees um, identifying information alongside whatever variables are in those datasets. Um, we basically obscured the information through um, a computational process. And that's all I can say about it right now. But the the key point is that you have to negotiate a way between the organizations um, uh, in a way that is comfortable for all of them to share their data. And a lot of that comes down to just protecting the identity of the individuals in the data sets. And to your second question, like how do we use the data, right? Um, so one potential use case that we're still working on right now is developing sort of what we call like screening protocols, right? So we identified several factors, several variables, several profiles of individuals that might be at risk of cycling. So what do we actually do with that? So now that we have these factors, these profiles, we return these findings to the organizations, and then um, we sort of work together with them and try to develop perhaps like a new way of screening people who actually enter these different systems. So now we have questions that we actually can target and and perhaps create an intake form that may ask specific questions that pertain to these factors of interest. And I don't know if that answers your question, but
No, it definitely does. I think
yeah.
it creates awareness for kind of where these people are coming from and what their circumstances are.
Mhm.
Because when you go into a hospital, typically the medical history that a physician were to ask, or any form that someone would get, are not going to ask anything about were you just in jail, or like where did you come from, like what's your housing situation. Any good physician should ask about like environmental factors like that. But in a lot of these screening forms, that doesn't necessarily make it to these forms. It just stays within like the medical history and the medical records, but doesn't go to any of these forms that can be used for external, like whatever you use it for, so that we can actually improve these outcomes. We want to take a quick break to remind you that this podcast is not intended for medical advice and is for educational and informational purposes only. We also want to remind you of our Instagram page at PreventPod, where we share various content relating to each episode that you can share with your friends if you enjoy our episode. And lastly, don't forget to sign up for our mailing list so you know right away when an episode goes up at www.thepreventivemedicinepodcast.com. And with that, let's get back into this episode. So we talked about one use case of kind of how data is used between a variety of sectors to hopefully improve some level of care, or at least awareness. After you collect this and you have, let's say, that screening form, what do you do with that? And how do you measure the impact of that? What does that screening form do and where does it go from there?
Sure, yeah. So with every project, we try to identify outcomes of interest. So in this case, for the screening form, an outcome of interest might be how many folks are actually uh, uh, taken into a specific program, or how many folks who have been identified for a specific risk factor, say, for example, like having behavioral health issues for the past 6 months could be a factor. And um, how many of these folks are actually pointed in the right direction? Are they given the services within, say, 1 to 3 months of their first encounter with the contact person in the social service? So that could be an outcome. And then another way of measuring it would be actually looking at whether or not individuals go back and cycle, right? Because that's obviously the initial goal.
Mm-hmm.
So we can do that statistically. We can track individuals who are being taken in by these various social services, do a longitudinal study, track them for a year, 2 years, 3 years, and then look at how often they actually re-enter like these sectors, and then compare that with individuals um, who entered these sectors before the screening form was implemented, and then in that way you can measure impact.
Definitely. So it sounds like a lot of this is the impact will be in the appropriate use of a variety of existing social services, whether that's services that are going to help find housing placement for these individuals, whether it's going to be appropriate services that are for behavioral health kind of things and helping with those issues, whether it's community health services that are going to be able to help them manage their health in a little bit better way. So it sounds like it's kind of the appropriate utilization is all those and identifying who needs what and getting that there. Otherwise, you're kind of just throwing things at people and you don't know who actually needs what. Is that appropriate?
Yeah, that's right.
Perfect. And so that's one of the things. But what about infrastructure? So are we building anything with these? Because right now we're mentioning like using existing services, using existing facilities, like physical facilities, or so what do we do about infrastructure? Do these help us build anything new?
Definitely. So I guess you could say like the form itself is considered like infrastructure, in a sense like we are developing this new process for
Mm-hmm.
existing social services to use. But I can think of some examples where um, uh, a new kind of treatment has resulted in the development of actual physical facilities. Um, and one of these examples could be, say, on the particular form, we also um, ask for these individuals' um, location or address. And in many cases, in especially with vulnerable groups, like the access to healthcare is very much tied to their neighborhood or the location
Definitely.
in which they frequent, because as you are probably aware, like neighborhoods differ in the amount of the accessibility of the facilities there and the cost as well. So if we find so this is just a hypothesis as well, because we haven't, we're still in the process of developing the screening form, so we don't actually know this. But say if we find a particular neighborhood um, that is being reported a lot on the form um, as part of this at-risk population, we could definitely use that as a petition to the city council, for example, to develop new facilities in that area. So that's one way we might address the question of infrastructure.
Definitely. And I think that's hugely important because what a lot of these places need to make these changes is overwhelming data. And at one point, you can like say, oh, these places need this kind of infrastructure because it's not there. But unless there's data and robust data to kind of back that up, people are more hesitant to make those changes and invest a significant amount of money, especially like in the city of Chicago, which is like chronically, we're short of budget. The city has no money. And it's very difficult to make a lot of these things happen. And if you just have overwhelming data that's kind of showing we need this is a significant public health issue, this is a significant issue that's impacting the health of many people, we can do a lot to prevent this, get on the front end of this, then I think people will be more likely to invest in those services. So that's definitely where that data can be used.
Yeah, and you could really get into the weeds of when it comes to infrastructure, you can really get into the weeds of this whole um, big data or data analysis thing. I know a project. I can't remember the authors, but um, they actually use mobile phone geolocation data to track folks in a neighborhood, um, and um, basically see how folks were accessing um, uh, various amenities such as public transport,
Hmm.
and they wanted to specifically look at individuals um, who had some form of disability. So, and to look at the time taken to travel between point A to point B, for example, and really like comparing that between different neighborhoods. So you can do interesting things like that and try to like compare, say, the accessibility of one neighborhood to another. So
Definitely. And I think that's once again incredibly important because we know, and we've talked about many times in this podcast, how accessibility and ease of transport and ease of use of a lot of these facilities helps people to stay on top of their issues. They're more likely to visit a physician when they need it. They're more likely to visit a community health area if they need it, more likely to access gyms, recreation areas, all those kinds of things. So if this data can be used for that to kind of improve infrastructure, improve public transportation, that's hugely beneficial. And that's exactly why we have Leoson on this podcast. Another project that you mentioned previously in that call was that of insurance backed psychiatric placement and various providers. And we know that psychiatric care and mental health is something that's hugely important, but there's like no psychiatrists. A lot of psychiatrists, I don't know if you're aware of this, but a lot of psychiatrists have like 6 month to like 1 year wait lists just because there aren't that many. And there's a lot of people who are having these kinds of needs. So, can you talk about that project a little bit?
sure. Um, so the project I mentioned, it may not speak directly to the problem you talked about, which is the scarcity of
Yeah,
psychiatrists
that's
in
fine.
general, and the cost as well. But it does speak peripherally to it. So we have this project that's going on where we're trying to involve psychiatric service providers and mental health professionals in um, what is known as the Crisis Assistance Response and Engagement Program. And that basically involves staffing 911 response teams in Chicago with mental health professionals. Um, there is the ostensible goal, which is to basically uh, sort of address behavioral health related 911 calls with actual behavioral health
Yeah, people
professionals.
who are trained in it.
Yeah, but there is that secondary goal that also speaks a little to what you just said, which is um, sort of co-opting as many uh, mental health professionals and psychiatric insurance-backed psychiatric service providers in the city of Chicago into a public program with the
Hmm.
hopes that more attention can be drawn to this area and more funding can be directed towards that area as well. And um, thereby, potentially attracting more psychiatrists or more people who want to be psychiatrists in the future. But to go back to that project, um, uh, the project basically focuses on reducing um, potential violent incidents involving police confrontation, especially in behavioral health calls, with the hope that mental health professionals are better at de-escalating um,
Hmm.
situations, especially with folks that are, um, overtly experiencing a mental health episode,
Yeah.
um, which may not be as easily recognized by um, law enforcement officials who are
Yep.
trained differently. Um, and so currently, that project we are in the process of developing the evaluation plan. So it's very apt to actually talk about this project because we are currently right now in the weeds of deciding like what data do we need from this
Yeah.
project. How can we use this data not only to spur on more programs like this in the future, but also to talk about uh, uh, advocating for mental health. So, like what you said, and inviting more public funding.
Definitely. So I guess this is a very pertinent question right now, and this is more so for my own curiosity. But how do you go about deciding what data you need, and kind of how do you actually get that data? Because this involves going to the EMS like services and whoever is answering these phone calls. You have to collect some sort of data from them, and especially if it's like verbal spoken word, are you kind of recording these dialogues and feeding them through some software and identifying what the topics are? How do you actually do this?
Great question. So, what you just suggested, like actually having the recorded calls, the interactions during uh, these dispatches, like we are hoping to get that
Yeah.
from um, basically the um, the responders as well as the 911 call
Hmm.
center, um, and the the fortunate thing is that we have worked with these organizations before in Chicago, so we do have a history of say working with um, uh, police response data. So we have getting access to the data is more simple in the sense like we just put in a new request and we say that this is part of our evaluation plan. Um, but getting access to what you mentioned, the recorded interactions, may be more complicated, and that's something that um, we have been talking to uh, individuals with the sheriff's office,
Yeah.
with the 911 call center about. To your first question about how we actually decide what pieces of data we need,
Hmm.
um, we try to divide it up into uh, uh, two main lines of questioning that we want to address. So the first one is obviously the outcome of this intervention, but the second one, and I argue that the second line of questioning is almost as important as the outcome of the intervention, is um, assessing whether how the program is actually executed. So implementation of the program itself. So like
Hmm.
internal evaluation. Um, so this, for example, can involve asking questions such as, um, are the behavioral health professionals comfortable with going out with police officers in these
Hmm.
dispatch teams? Do they feel that they are well trained to deal with these high stakes situations? These kinds of questions. So usually we start from these top level questions, and then we sort of narrow it down to, okay, if we want to really evaluate this, like uh, what information do we need? So for the question regarding like training, for example, um, we we could say like, oh, perhaps you wanna pull the training materials, you wanna pull um, data as to like how long these behavioral health professionals spent in
Hmm.
dispatch training. We wanna actually maybe send out a survey um, periodically to these folks to ask them, is the training adequate? On a scale of 1 to 5, that kind of thing.
Sure.
So we're actually working on all this right now. So that's a really good question.
Perfect. And then I guess another thing for my curiosity, we were discussing earlier
Mhm.
in this podcast how oftentimes a lot of the outcomes and a lot of the data that's collected We need to make sure that it's clinically focused and it's relevant to what we actually want the outcomes to be. How do you make sure that the stays focused on this? Do you have like someone on the team that is acutely trained within some of these things and looking forward to and knows kind of what we want these outcomes to be? Or how do you set those outcome goals when you're working from the top down approach, like you were mentioning?
Yeah, so your intuition is pretty much correct. So we have folks at the health lab who have uh, who have expertise in specific areas of healthcare research.
Yeah.
So we have a research director, for example, who's um, very much um, involved in designing the the evaluation process from the top down perspective. So like what needs to go here, what needs to be um, uh, what models do we use so that we can draw the appropriate conclusions. And then we also have a principal investigator on the team who is trained in um, healthcare. We have a physician, we have an economist, um, and they are the ones who provide input as to which measures are the most important. Um, yes.
Got it. And now the last question I had on this project, and this is sorry for the listeners back home. This is all for like my curiosity's sake at this point, just because I'm trying to understand how these things work and how they play into kind of the bigger picture of health. Because you can prevent a lot of things from just this simple. Well, it's not really simple; it's pretty robust, but from this one kind of piece of data collection, and hopefully, if it gets applied, you can do a lot. So when it comes down to it, you are collecting data from like EMS, these phone calls. You have to have some sort of data collected from the actual interaction with whoever is having a mental health symptom, whatever it may be. And you also have to have data on the outcome. And you also have to have willing participants from like the healthcare side of whoever these mental health providers are, whether psychiatrists, psychologists, whoever it may be. How do you get them all to play together? And do you have to kind of disclose that all? Are they all willing partners?
Yeah. So I think to actually pull a project off like this, it takes years of sort of building relationships as well. So we are fortunate in the sense that um, we have long-standing relationships with these organizations. We also have folks who um, uh, basically have networks across the health lab, across the EMS uh, service providers, the sheriff's office, and then basically it's meetings after meetings and co-opting more and more
Mm-hmm.
people. And I think the essential component is actually getting um, a lot of the legal documents drafted up,
Mm-hmm.
and that involves sort of um, a statement of work which lays out like how the entire experiment or how the entire intervention is going to be conducted, and also a data security policy. These two pieces are the most important. And once you are able to get all your various stakeholders to agree on these two things, then uh, that's where you can give the green light.
Yeah.
But but
It
negotiating these things really involves um, uh, many different stakeholders,
Sure. It
as you
sounds like
mentioned.
a lot of work, and there's just so much that goes on behind the scenes that a lot of people don't know of what's going on. And either they will never ever hear of this project, or it's something that'll just be going in the background and no one will ever acknowledge it. And that's why I want to have people such as yourself come on this podcast to talk about these things because they are all impacting our health to some extent or another. They're preventing maybe some unnecessary use of force on someone, which is definitely a way to protect someone's health. So this is why I want you on the podcast. And one of the other questions I have for you now here is we've talked so much about these social services and a lot of kind of what happens. And between the lens of prevention and kind of acting on an acute situation, do you think that a lot of existing community social services, given that you have so many relationships, can actually help prevent problems from occurring? Or are they most active and best at solving acute problems?
I think that many social services, such as homelessness shelters, for example, they definitely provide a lot of acute assistance for a certain point in time, right? So, um, there's an emergency, someone needs housing right now, they can do that. And um, a lot of these social services are actually focused on that. So I do believe that. In terms of preventative care, um, I would say that it is possible. I wouldn't say that they um, that a lot of social services have the same amount of capacity to provide preventative care as compared to solving acute problems. And the reason for that is not really, it has nothing to do with their mission or their motivations, because, um, you know, I've talked to many people in these social services, and all of them would definitely, agree with the importance of preventative care, and as well
Hmm.
as the fact that if in an ideal world we don't want people to come in at all,
For
because
sure.
that that would mean that they have succeeded in their cause. Um, but the difficulty in terms of providing preventative care is that, especially at the social services level, you're looking at a lot of vulnerable groups of individuals, right? And if you want to provide preventative care, if you want to um, sort of stop the needle before it even turns,
Hmm.
you you have to identify these vulnerabilities and these groups of people even before they enter the social services. And to do that, you need information from elsewhere. For most of these organizations, they need information that doesn't come from their own organization. So I'm kind of borrowing the answer from like one of my previous answers to your questions um, about the whole like combining data from different
Hmm.
social services, right? Because that's where the difficulty lies. Like, say for a homelessness shelter, if they want to, if they know like a bulk of their population are, say, like elderly folks who have a lot of physical health problems as well, to identify um, these risky people and to direct them to services that may get them to permanent housing in the near future, even before they enter like the homelessness system,
Hmm.
they will need this data, right, from the healthcare system, which is very very hard for them to obtain. So I would say that um, if we want to advance preventative medicine in the social services sector, definitely more of these collaborations are needed. We need to um, and not just research, right? Because obviously I'm from a research outfit, so there's some bias to it. It's like, oh
Hmm.
yeah, let's just do a study, like combine,
Yeah.
um, get these institutions to collaborate. But they also, I believe, like a lot of these institutions also require um, uh, uh, practical collaborations that are organic, that they start on their own and they talk to each other, and they develop programs that actually are a united effort instead of just, oh, I'm working on this neighborhood, I'm this one shelter. um,
Yeah. First off, thank you so much for the work that you're doing, because this is you're filling the gap that you just talked about by kind of providing data from all of these areas. And this is kind of exactly what I was thinking of, why it's so difficult to provide preventive medicine at a policy level, because you have to look at those vulnerable populations that are not quote unquote vulnerable yet because they haven't entered the system. How do we collect data on something from, there's no institution that's collecting these data on them? You just have to kind of get data from the wild. And that is where a lot of your projects come in. That's where a lot of that collaboration comes in, because it kind of fills in those gray spaces. So it speaks to the issue. It speaks to the difficulty of kind of implementing preventive services and preventive policies at that broad level. I hope we can have more people who are doing things like you, so that we can do this, because I've talked about in this podcast previously. I think the biggest thing we can do for preventive medicine is not exercise and eat properly, although that's hugely important. The biggest thing we can do is implement policies, designs, and kind of arrange our environment in a way that promotes prevention. And a lot of that's very difficult to do without the data. And that's why I have you on. That's why I've been chasing this topic. I have several other guests that I'm trying to get on to talk about this from a variety of angles. So thank you so much for doing this work.
of course, yeah, and I totally concur with what you said about the importance of the environment. I mean, it's people's behaviors that matter a lot.
Exactly.
Mm,
And as we start wrapping this up, our famous question is, if someone asks you how to get healthy at a Starbucks, what do you tell them? But I'm going to modify it a little bit for you. So in this one, if you become a massively popular, famous researcher, which typically researchers don't get that way, unfortunately, if you were at a Starbucks, someone stops you and asks you, how does data contribute to health? What do you tell them?
I would say that, especially in healthcare, data is essential in studying any kind of intervention or policy that's administered at scale. And this is because, um, usually when you implement a healthcare intervention or a project, a policy, it involves a lot of individuals, and it definitely involves a lot of resources, time, investment, uh, uh, manpower. Even, for example, the project where we are sending in behavioral health professionals with 911 responders, right?
Mm-hmm.
So data is important in the sense that because there's so much investment involved, and every investment is kind of uh, involves a kind of trade-off or an opportunity cost, right? Like resources you're spending here means resources you're not spending somewhere else. So um, and with projects at this scale, you you can't really afford to um, put a whole lot of resources into it and then not understand how these resources are being used. Um, if you're not seeing the results, you also have to understand like why you're not seeing the results. So
Mm-hmm.
this is where data comes in. Like it's implementation. So evaluating both the outcome but also the implementation is important as well. Um, just to understand whether your resources are being used well, whether they're going to the right place, if there are gaps, how do you fill them? And to answer all of these questions, you would need the data that's being streamed in whenever you're executing some sort of project. So,
Definitely. Without the data, we're going in blind, and everything that we do should theoretically be data driven to some extent. The interventions that we're implementing, the outcomes that we're measuring, how we change those interventions to have better outcomes, everything. Thank you so much, Leoson, for coming on this podcast. I found this greatly illuminating. I hope our listeners back home did as well. And if you did, then please drop us a review, share this with your friends and whatnot. But Leoson, thank you so much for your time, and thank you so much for coming on.